Thank you for joining us today, no matter when or how you're tuning in. I'm Dr. John Iskander. It's my pleasure to welcome you to CDC Public Health Grand Rounds for January 2017 on the unique challenges of opioid use disorder in women. This is a picture of one of my closest friends, someone I hoped could be here herself. I'm telling her story on behalf of her family and friends. She was a Peace Corps volunteer, a dedicated public health worker, a champion for persons living with HIV/AIDS, and a certified addiction peer counselor. She had a medical condition for which she was prescribed opioids. Now I know, based on medical and personal information, that opioids contributed to my friend's recent death. As a physician, I understand that this was not a moral failing, but a recurrence of a chronic disease, addiction. As a friend and a classmate who wrote her obituary, I am heartbroken. The opioid epidemic affects all of us. Today we will learn about what each of us can do to help prevent other needless losses. Public Health Grand Rounds has continuing education credits available for physicians, nurses, pharmacists, veterinarians, health educators, and others. Please see the Grand Rounds website for additional details. This is Ms. Fraser's and Dr. Terplin's disclosure for today's presentation. Grand Rounds is available on all of your favorite web and social media sites. We are also live tweeting today. Please use hashtag CDC Grand Rounds. We have a featured video segment on YouTube and our website called Beyond the Data, which is posted shortly after the session. This month's segment features my interview with Dr. Terplin. We've also partnered with the CDC Library to feature scientific articles relevant to this session, available at cdc.gov/scienceclips. Here's a preview of upcoming Grand Round sessions. Please join us live or on the web at your convenience. In addition to our outstanding speakers, I'd like to acknowledge the important contributions of the individuals listed here, and I'd like to give special thanks to Cheryl Thompson and Jessica Titel and their colleagues from the HHS Office on Women's Health who hosted this session. It's now my pleasure to introduce the CDC Director, Dr. Tom Frieden, who originated Public Health Grand Rounds more than 7 years ago as a way to build the common scientific culture of public health.
Thank you very much, John, and thank you for sharing that painful personal story. The common scientific culture of public health is indeed the goal of Public Health Grand Rounds, and that common culture is based on an understanding that the data that we work on, the policies that we implement, are about people's lives, each of them about the stories of someone's mother or father or child or brother or sister, and the impact that we can have on that has an enormous impact, not just on that family, but on communities and far into the future. The common scientific culture is part of a broader effort to strengthen the commons, the sense that we as an organization, we as a society share an interest in progress, and that when some of us benefit, all of us benefit, and when some of us have problems or move backwards, all of us are diminished in some way. I want to thank everyone who's been so important to making Public Health Grand Rounds so successful. They have done what I hoped they would do in allowing us to look at cutting-edge issues, look at the science, look at the impact, look at the program, and then share among ourselves how can we be even more effective, learn from each other, learn from the other programs, and use that information to strengthen our own programs. Last month, new CDC data showed that more than 33,000 Americans died from opioid overdose in 2015. This is a continuing increase, and in fact, an increase in just 1 year of 15%. More people now die from opioids than from motor vehicle crashes. And it's having an epidemic and the epidemic is having an impact on communities throughout the country. Death rates have increased in men and women in most areas of the country and in most ages. It's had a particularly significant impact on women's health. From 1999 to 2010, overdose deaths from prescription pain medications increased fourfold. Heroin use has been increasing faster among women than men and doubled in the decade between 2002 and 2013. And we're seeing now a big increase in deaths from synthetic opioids, including fentanyl. Today's speakers will discuss how we can better address opioid use and misuse by understanding the specific patterns and needs of different populations. Women who use opioids need and deserve special attention. We have to recognize that in our society, we do not effectively manage either pain or addiction. There are still people in pain who are undertreated, and there is a massive under-recognition and under-treatment of addiction. We also need to ensure that there is access to effective medications, but that there is a broader sense of what it is to manage these two conditions. They involve more than just opiates. They involve more than just medications, but a whole range of potentially highly effective interventions. Today's session is inspired by work being carried out across HHS. That includes the first ever national meeting on the opioid misuse epidemic among women this past September, a newly available white paper from the Office of Women's Health, and of course other parts of HHS, including FDA, SAMHSA, NIDA, are all vigorously involved in this. We're continuing to address the challenges posed by the opioid epidemic, focusing on better data so we understand the causes and drivers of this epidemic, strengthening state efforts so that they can take measures at the state level with policy interventions and others that can make a big difference and that we can all learn from, and supplying healthcare providers with the tools they need and supporting them, whether it's with prescription guidelines or better connections between electronic health records and prescription drug monitoring programs. There are important best practices that we can learn from. These include some proven public health strategies that you'll hear about in this session. And I think we're all hopeful that with the increased recognition of the epidemic of opiate overdose, we will begin to see a turning of the tide of the large numbers of deaths. We're not there yet, but we've got a strong foundation and groundwork. It's a big challenge, but it's going to require a lot of effort, a lot of creativity, and a lot of partnerships. And for that reason, I really greatly appreciate our speakers coming here today. Thank you very much.
Our first speaker today is Dr. Karen Mack.
Hello. Thank you all for coming out today. We appreciate your interest in this important topic. I'm Karen Mack, a Division Associate Director for Science at CDC's Injury Center. A new Surgeon General's report finds alcohol and drug misuse and severe substance use disorders, commonly called addiction, to be one of America's most pressing public health concerns. Nearly 21 million Americans, more than the number of people who have all cancers combined, suffer from substance use disorders. Alcohol and drug addiction take an enormous toll on individuals, families, and communities. Most Americans know someone who has been touched by an alcohol or drug use disorder, yet 90% of people with a substance use disorder are not getting treatment. The report makes it clear that substance misuse is an underappreciated but critical public health challenge that could lead to substance use disorders such as addiction. In 2015, nearly 21.2 million women used an illicit drug or misused a prescription medication in the past year. 2.8 million women met the diagnostic criteria for substance use disorder, and approximately 28.3 million reported binge drinking in the past month. This large, at-risk population of women can benefit from appropriate screening, prevention, and treatment services. The United States is in the midst of an opioid overdose epidemic, driven largely by the overprescribing of opioid medications. More recently, a sharp rise in heroin-related overdose deaths is a new development in an epidemic that is impacting every corner of this country. After outlining the public health burden, I will briefly discuss the federal approach to prevention. CDC has been tracking rising overdoses for over a decade, In the early 2000s, CDC epidemiologists took a closer look at the data when they noticed a substantial increase in the number of deaths from unintentional poisonings. Drug overdoses are a problem our nation has faced before, and it has been pointed out that history offers grounds for optimism that this epidemic can be controlled. Sometimes pictures tell the story better than words. This is certainly true in this epidemic. This map series shows county-level drug overdose mortality rates shifting between 2002 and 2014. Prescription drug overdoses are among a few causes of death that are on the rise, and the trends, as evidenced here, provide stark contrasts within the U.S. and over time. Every state has seen dramatic increases in mortality rates, with some states in Appalachia and the Southwest being among the hardest hit. The amount of opioid prescriptions dispensed has quadrupled since 1999, but the level of pain that Americans report remains unchanged. Healthcare providers wrote more than 250 million opioid prescriptions in 2013. That is enough for all 240 million adults in the United States to have a bottle of pills. Healthcare providers in the highest opioid prescribing state, Alabama, wrote almost 3 times as many of these prescriptions per person as the lowest prescribing state, Hawaii. These variations in prescriptions can't be explained by the underlying health status of the population. Preliminary reports indicate recent drops in the number of opioid prescriptions, but this trend varies by drug. For example, the number of patients receiving oxycodone remains level, while the number receiving tramadol has increased. Further, the proportion of opioid recipients also receiving benzodiazepine scripts has increased, and more women than men are given opioid and benzodiazepine scripts at the same time. In 2013, CDC released a vital signs that examined prescription opioid overdoses among women, which showed that these deaths skyrocketed among women over the past decade. Prescription opioid overdose deaths increased 400% among women between 1999 and 2010, and on average, every 3 minutes, a woman went to the emergency department for opioid prescription misuse or abuse. That vital signs included data through 2010, and we now have data through 2015. Since 1999, there have been over 71,800 prescription opioid-related deaths among women. Our mothers, wives, sisters, daughters are dying from these overdoses at rates never seen before, and this needs to stop. Since 2007, more women have died annually from a drug overdose than from a motor vehicle crash. Current data show that age-adjusted overdose death rates for women continue to rise for all opioids, notably because of rises in deaths from heroin and synthetic opioids like fentanyl. Methadone-related overdose deaths appear to be declining. In 2015, on average, 31 women died every day from an opioid-related drug overdose. In this graph, you can see how one main driver of the increase in opioid overdose deaths is the sharp increase in the prescribing of these drugs. Since 1999, sales of prescription opioids increased significantly through 2011. This graph shows the relationship between the sales of opioids, the green line with the diamond markers, and the deaths from them among women, the orange line. As the amount of opioids sold increased, so did the number of deaths. Recent analyses showed that among women who used heroin during the previous year, 7 out of 10 reported also misusing prescription opioids. The non-medical use of prescription opioids is a strong risk factor for heroin use. Although heroin use among people who use prescription opioids for non-medical reasons is rare, the majority of current heroin users report having previously misused prescription opioids. Further, recent work found no evidence to support an assertion that policies to curb opioid prescribing are leading to heroin overdoses. Now I'd like to highlight a few federal efforts to curb the epidemic. At CDC, we have 3 priority areas. They are first, to improve data quality and track trends to monitor the epidemic. Second, to strengthen state efforts by scaling up effective public health interventions. Third, to enhance patient safety by supplying healthcare providers with data, tools, and guidance for evidence-based decision-making. In March 2016, CDC finalized an opioid prescribing guideline for primary care providers for chronic pain treatment outside of active cancer, palliative, and end-of-life care. A guideline was needed to better align opioid prescribing practices in primary care settings, which can vary widely across the country, with the best available evidence to ensure safe, effective pain management. The guideline is not a rule, regulation, or law. The guideline does not deny access to opioid pain medication as an option for pain management. Rather, the guideline is intended to inform clinicians' discussions with patients and their prescribing decisions. 3 principles in the guideline are key to improving patient care. First, outside of end-of-life care, non-opioid therapy should be preferred for chronic pain. Second, when opioids are used, the lowest possible effective dose should be prescribed. Third, providers should exercise caution when prescribing opioids and monitor all patients closely using prescription drug monitoring programs, PDMPs, and other means. The success of the guideline hinges on effective dissemination. To this end, CDC identified 4 priority areas to maximize uptake and use. This includes developing translation and communication materials to make the guideline more accessible, educating providers with training, and working with health systems to integrate the guideline into clinical decision support tools and practice protocols. Insurers can implement activities as well, such as proactively using claims information to identify potentially risky prescribing practices. Improving insurance coverage for non-pharmacological treatments is important too. We'll look at steps 1 and 2 more closely. CDC developed a suite of materials that distill the guideline into lay-friendly information, as well as materials that assist providers in implementing the recommendations. Products include fact sheets for patients, posters, an audio podcast, and infographics. One sheet focuses on pregnancy and opioid pain medications for women who are pregnant or planning to become pregnant. Another tool available from CDC is the checklist for prescribing opioids for chronic pain. CDC worked with partners to develop this checklist, outlining critical steps in providing safer, more effective care for patients with chronic pain. In December, CDC released a new opioid guide app, which makes it easier to apply the recommendations into clinical practice by putting the entire guideline, tools, and resources in the palm of your hand. For example, the app can be used to calculate total daily opioid dose and provides a motivational interviewing feature. A webinar series launched in June, and it has completed 7 offerings to date. The webinar materials are available for free online. CDC partnered with the University of Washington to release the series of webinars with continuing education opportunities for providers that covers when and how opioids should be initiated for chronic pain, how to assess risk and address harms of opioid use, and when and how opioids should be discontinued. In 2015, CDC launched the Overdose Prevention in States Initiative. We've structured this evidence-based program to enhance and maximize the use of PDMPs, implement community, insurer, or health system interventions, conduct evaluations to see if changes in legislative policy and regulation are making a difference, and enhance the quality and timeliness of surveillance data. Finally, there are rapid response projects, which give states the flexibility to redirect and target a hotspot area or emerging issue, such as the recent overdoses related to fentanyl. Increased resources allowed CDC to initiate 2 new programs in 2016, and CDC is now funding a total of 44 states and Washington, D.C. to prevent opioid overdoses. U.S. Health and Human Services Secretary Sylvia Burwell announced a targeted initiative aimed at reducing prescription opioid and heroin-related overdose and dependence. It focused on 3 priority areas that tackle the opioid crisis and significantly impact those struggling with substance use disorders. First is to provide training and educational resources to assist health professionals in making informed prescribing decisions. Second is to support increasing use of naloxone, such as Narcan and others, through the development, review, and approval of new naloxone products and delivery options. Third, the Secretary supports expanding the use of medication-assisted treatment, which is a comprehensive way to address the needs of individuals that combines the use of medication with counseling and behavioral therapies to treat substance use disorders. This includes launching a grant program to improve access to MAT services. There are 3 examples of HHS activities we like to mention in particular. The first is the white paper that Dr. Frieden mentioned by the HHS Office of Women's Health as part of an initiative to examine the prevention, treatment, and recovery issues for women who misuse, who have use disorders, or overdose on opioids. The second is a funding opportunity announcement from the Substance Abuse and Mental Health Services Administration. The state-targeted response to the Opioid Crisis Grant Program will address the opioid crisis by increasing access to treatment, reducing unmet treatment need, and providing prevention, treatment, and recovery activities for opioid use disorder, including prescription opioids as well as illicit drugs such as heroin. These grants will be awarded to states and territories. And the third is a special issue of the journal Addictive Behaviors, which features more than a dozen articles related to the public health issue of the non-medical use of prescription drugs. Many articles are funded by NIH's National Institute on Drug Abuse. Surgeon General Vivek Murthy sent a letter in August to 2.3 million American health professionals, encouraging them to be leaders in a national movement to turn the tide on the nation's prescription opioid epidemic. He urged clinicians to visit a website where they could pledge their commitment to combating opioid misuse and help lead a shift in the public perception of addiction so it is treated as a chronic illness rather than a moral failing. The letter was accompanied by a pocket card, and we have one here if you want to see what it looks like. It marks the first time that a U.S. Surgeon General has sent a letter directly to the nation's health professionals seeking their support in addressing the public health crisis. And the pocket card outlines CDC's opioid prescribing guideline. In conclusion, while the U.S. is in the midst of a crisis and women's lives have been particularly affected, there are evidence-based solutions that offer optimism that we can turn the tide and save lives. Our next speaker will be Linda Frazier.
Good afternoon. I'm Linda Frazier, and it's my pleasure to talk to you today about a topic that's very near and dear to me. As a nurse, health educator, and recovery advocate, I have over 30 years' experience in behavioral health, including adolescent and women's health, inpatient and outpatient mental health, and addiction treatment, particularly medication-assisted treatment. I am a survivor of sexual assault, and I am proud to say I come from a family in recovery. If you are watching Dr. Mack's slides, particularly the map, or the maps, you may have noticed, if you are looking at New England, that the state of Maine went from being green and slightly orange to being bright red between 2007 and 2014. In 2006, I worked in Maine, and my team and I were presenting and working with disturbing trend data indicating an increase in treatment admissions for young people 18 to 25 years old for opiate dependency. In 2006, not many people wanted to talk to us, and they weren't very interested in our concern about preventing increasing heroin or needle use in the state. So today, I am cautiously optimistic. Unlike 2006, we have people like yourselves that are engaged and eager to address this opiate epidemic. There is consensus on the need for access and for funding of substance use disorder treatment services. And the recent release of the Surgeon General's report on alcohol, drugs, and health really will help build momentum to turn the tide. As providers, we need to be aware of the biological and sociocultural differences that make women more vulnerable to the consequences of substance use. Services must integrate access to medications for treatment, effective cognitive, behavioral, and trauma-informed interventions, and be sensitive to women's distinctive and complex recovery support needs as they balance their roles as caregivers for children and families. Capacity to address a broad array of recovery support needs like care coordination, transportation, child care, peer recovery support, and safe housing are needed. And they're not only needed while in treatment, but in an ongoing way to support and sustain recovery. Smaller body mass and differences in metabolism, absorption, and elimination of medications and substances put women at increased risk for dependency and health consequences of the use over a shorter period of time. This accelerated process is sometimes called telescoping and means that women can have more severe opiate withdrawal and be at a higher risk for opiate overdose. Women are more likely than men to define themselves in terms of their relationships and their obligations, and they are strongly influenced by familial substance use. Initiation of substance use typically begins after introduction by a family member, close friend, peer, or an intimate partner. Histories of trauma, PTSD, and interpersonal violence are common among women and include rape, assault, and partner violence. Women are also more likely to have periods of problematic use of substances over their lifetime. And drug use is increasing among adolescent girls and women. Dr. Nora Volkov, the director of the National Institute of Drug Abuse, calls these trends among girls quite worrisome because between 12 and 17 years of age, girls have significantly higher rates of abuse of all psychotherapeutics, including opiates. And stimulant abuse is 60 to 70% higher among girls, and they have higher rates of ecstasy and inhalant use. Women and girls' pathways to use differ from men and boys. They are more likely to have co-occurring disorders and have higher rates of mood disorders like depression and anxiety. They may use substances to improve mood, relax, reduce stress, focus attention, gain energy, increase confidence, or even control weight. And women over 55 are the largest consumers of prescription drugs. Women are more likely than men to live longer, experience pain, and be prescribed addictive medications. Healthcare professionals frequently miss the signs of addiction in women and girls, who are more likely to receive long-term prescriptions for sedatives and analgesics for depression, anxiety, or other disorders. All of these factors underscore the importance of screening, brief intervention, and referral to treatment for girls and women. We also see gender differences in the experience of care reported by women. Social stigma, the demands of caring for young children or family members, fear of losing child custody can all delay women's entry into treatment. Histories of trauma, interpersonal violence, and the pressure to choose between treatment and relationship or family obligations also contribute to delays in seeking treatment, which means women have more acute stages of addiction and more serious health complications when they in fact get engaged in care. The risks for substance use and substance use disorders are best understood by looking at the cultural context of women's lives. Understanding cultural differences among women is vital to designing and implementing effective substance use disorders treatment services. Culturally responsive care improves short and long-term outcomes for women. The Substance Abuse and Mental Health Service Administration's Center for Substance Abuse Treatment has developed a comprehensive model of care for women that includes 5 core components of gender-responsive services. They address women's unique experience, they are trauma-informed, they use relational approaches, are comprehensive, and provide a safe and healing environment. Some women will also benefit from gender-specific services, which are services that only serve women. This comprehensive model also involves addressing the 6 fundamental principles of trauma-informed care. Building safety and trust requires a context where there is meaningful collaboration through shared power and decision-making. Women need a voice and a choice in their care decisions, and cultural, historical, and gender issues must be recognized and valued if they are to stay engaged in services. Many treatment interventions that have demonstrated effectiveness with males are also effective with women. However, treatment access, engagement, and retention among women improves when evidence-based practices are implemented with the specific needs of women in mind. For example, integrated approaches are important for women with co-occurring disorders, and programs like Seeking Safety, a cognitive behavioral approach for recovery from substance abuse and trauma, can be helpful, as can access to medication-assisted treatment and overdose prevention, or the use of Narcan, which may be important since women tend to delay getting help for a problem with substances and get help at later stages of the disease. It's called addiction. As in the management of other chronic conditions, treatment is important, but support in sustaining recovery is critical. SAMHSA also identifies 4 major areas that support recovery. These include health, home, purpose, and community. Recovery happens by building on small successes, and optimism and belief in women and girls' resiliency is key to hope and builds self-efficacy and success. When providers and recovering women are working together effectively, it is not only important to be clear, but also to be respectful. Language can disempower women, but it can also be used to empower them. Don Coyes says this best: if you want to care for something, you call it a flower. If you want to kill something, you call it a weed. So judgment and disrespect in terminology does not help with treatment engagement or patient activation. Creating a safe environment requires attention to both language and nonverbal communication. Use a motivational rather than a confrontational approach. At the heart of motivational techniques is unconditional positive regard. So for example, team training on focusing on women's strengths and coping strategies, and on sensitivity and awareness of the needs to use neutral, non-threatening language and postures can be critical to working with anyone with trauma. Trauma can also lead to hyperarousal, and the appearance of threatening behavior by staff can jeopardize stabilization and lead to clients leaving services against medical advice. Improving outcomes for women with opioid dependency and their families requires providing a full continuum of services and recovery supports, including improved screening for substance use disorders, access to medications, and implementation of gender-responsive, trauma-informed informed services. You can find a significant number of resources on women at the Substance Abuse and Mental Health Services website here, that's listed here. There are webinar trainings and online courses that are also available at healthknowledge.org. And training can be requested from SAMHSA through the Women, Children, Families Project. Thank you. Our next speaker is Mishka Terplin.
Good afternoon. My name's Mishka Terplin. I'm an obstetrician gynecologist. I'm also an addiction medicine provider, and I want to thank you for inviting me here. I'm honored to be here at CDC, and I'm also touched to be here in Atlanta the day following the day that we honor the legacy of Dr. Martin Luther King. I want to begin with the observation that women and men are different. There are biological differences related to reproductive capacity, as well as differences in the cultural constructions of gender, which include gender roles and gender-based violence. And although I acknowledge that gender and sex are neither binary nor fixed, for the purposes of this presentation, I'm going to use the terms men and women. The life course of women is different from that of men due to their reproductive capacity. This figure shows that in the United States, the average woman wants 2 children, which means she spends 5 years getting pregnant, and immediately postpartum. And she spends 30 years of her life trying to avoid pregnancy. Now, whereas we have focused much of our public health programming in the important period of pregnancy, I want to focus on the other points along the reproductive health life course. Women, as we heard, bear a larger behavioral health burden than men. And while they may have lower rates of addiction, rates of mental illness, including depression, SMI, etc., are higher. Consequently, women use more prescription psychotropic medications than men, including opioids. And today, women are initiating opioid misuse at a rate greater than that of men. About 3,300 women per day initiate opioid misuse in the United States. And this is contributing to the change in the opioid epidemic, which is becoming increasingly young, white, and female. I think it's important to look at reproductive health along a substance use continuum. We know that adolescents who use substances are more likely to become sexually active earlier. They're more likely to engage in risky sex, which means sex without condoms. They're more likely to acquire a sexually transmitted infection, to have an unintended pregnancy, and to have an abortion. There's also a relationship between opioid misuse and HIV, a relationship that's more pronounced among women with histories of violence and abuse. And finally, for women who are in treatment for addiction, they're less likely than other women to use contraception. And when they use contraception, it's less likely to be an effective method. And therefore, they're at higher risk of an unintended pregnancy. So when women come to seek services, they have concerns across multiple different health domains. However, our system of care is siloed. We've built separate structures to house separate domains of health. And the care you get is determined by the silo in which you walk. And not only does this not meet the needs of individuals, but it's inefficient and it's costly. So this slide shows the consequences of siloed care. It's, I think, obvious that the cost of mental health care is higher for individuals with depression than individuals without. But it might be surprising that actual medical expenditures are higher for those with depression than those without depression. In other words, without addressing behavioral health needs, the cost of medical care is higher. So the solution to this mismatch between what people need and what the actual care is that they receive is integration. And this concept of integration is embedded in the Affordable Care Act. And it means a couple of different things. It means the integration of mental health and addiction services under a behavioral health umbrella, and it means the integration of behavioral health into somatic health. And I would argue it also should mean the integration of reproductive health services into all of that. There's another important part of the ACA, and that's parity, which addresses equity and means from an insurance perspective, if you provide coverage for somatic medical services, you have to provide coverage for mental health services. In other words, we're not just covering people from their necks down. And this is well understood by NIDA. This is a slide from NIDA, National Institute of Drug Abuse. Treating a behavioral disorder must go beyond just fixing the chemistry. We need to treat the whole person. But what if this whole person is a woman? So I looked at the websites of NIDA, SAMHSA, the Substance Abuse Mental Health Services Administration, and ASAM, the American Society of Addiction Medicine. And I typed the top of each column, I typed that term into the search engine, and the numbers correspond to the hits I got. And you can see that HIV is the most prevalent of these terms, which speaks to the success of the federal response to the HIV epidemic. There are also a lot of hits for pregnancy, which illustrates our focus on the pregnancy box and to the exclusion of other stages along the reproductive health life course. As you can see, there are very few hits for the terms reproductive health, sexual health, and contraception. And this pattern is seen again in the textbook, The Principles of Drug Addiction Treatment. There's a small section on pregnancy, a larger one on HIV, and there's no mention in this book of the terms contraception, reproductive health, or sexual health. The only glimmer we kind of get of this is the sentence I highlighted. It is also important that treatment be appropriate to the individual's age, gender, ethnicity, and culture. So you can see there's gaps between our principles and what we do in practice. We speak about the importance of holism, but there's certain domains that are more included than others. And we recognize the importance of integration, but reproductive health and contraception lag. And absent inclusion of reproductive health, we have established inequities, in particular for women with substance use disorder, and these inequities will play out across their lifespans. So really, instead of thinking of reproductive health and substance use, misuse, and addiction as separate silos, we have to bring them together. And we have to think about opportunities for public health programming at the intersections of these two domains. So I want to share with you two examples of public health at the intersections between these. The first involves bringing the silo of reproductive health into public health programming for people who use drugs. And this was a collaboration with the Baltimore City Health Department Syringe Exchange Program. There's been syringe exchange in Baltimore City embedded in the health department for almost 20 years. About 8 years ago, we opened a site in what's called the Red Light District, an area of strip clubs and dance clubs, and we noticed that over about 50% of all people who exchanged syringes at that site were women, and almost all of them had an unmet reproductive health need. So in this van here, we established a clinic that initially provided pregnancy testing and Depo-Provera contraceptive injections, and expanded to provide other more comprehensive services. And what we found was that not only was this acceptable and feasible to do, but that the women kept coming back for their contraceptive injections. And we also found that it was effective and inexpensive, a cost of about $85 per client total, with the potential to reduce unintended pregnancies. The second example is one of bringing the silo of reproductive health into addiction treatment. Addiction treatment is an underutilized location for the provision of reproductive health services and an opportunity to address sexually transmitted infections, to decrease unintended pregnancies, and thereby actually provide a primary prevention strategy for preventing substance-exposed newborns. And this was, we called the Baltimore Reproductive Health Initiative. It's ongoing. It was funded by a small grant from the ABLE Foundation, and it had 3 parts: screening, education, and service delivery. So screening, we utilized the one key question, which is, would you like to get pregnant in the next year? And I like this question. It's client-focused, it's non-judgmental, and it's closed-ended, so it leads easy to triage. If the answer is no or maybe, you follow up with, well, what are you using for birth control? And we embedded this. Every single woman at drug treatment intake is asked this question at the pilot sites, and then periodically thereafter. So these are unpublished data. It's an ongoing project from 2 of the sites. It's about 6 months of work. And you can see that of the 130 women that we served, about 2/3 had an unmet contraceptive need, of whom 80% left that visit with the contraceptive method of their choice. And the most popular choices being the long-acting reversible contraceptive methods, the implant followed by the progesterone-containing IUD. So in conclusion, I hope I've shown that there's many opportunities for prevention at the intersections of reproductive health, substance use, misuse, and addiction. And that through integration, we can minimize disparities in women's health and move towards realizing greater equality and addressing gender-based injustices. Thank you.
Thank you for that. We're going to open it up for questions. We'll take questions in the room as well as questions online. And I'm going to go first to Susan.
Thank you. I want to encourage our viewers to send their questions to grandrounds@cdc.gov. First of our questions for Dr. Mack. Can you explain why there are 6 states not included in the opioid initiative as indicated on the map shown during your presentation?
So we work with states and open those opportunities up. I don't know that I can share particulars on those 6 states, but I can follow up and get someone and get back to them about their opportunities to them.
Seeing none in the room, we'll go ahead with additional online questions. We have a group rate, opioid impact on pregnant moms and drug-affected babies. What's being done on this at a federal level?
So I don't work at the federal level, but there's a huge amount of activity at the federal level related to opioids, pregnancy, parenting, and children. There's been a whole series of recent legislations, including the CARA Act, that as well as that has filtered down to state levels. It's not uncommon now. I think almost every state has some sort of NAS-related task force, and there's the goal really, just to speak to this, which is having good collaboration between substance use disorder treatment providers, prenatal care providers, and child welfare, and really finding ways to bring all 3 of those to the table and to think about opioid use within that reproductive health lifespan context. So not just pregnancy, not just postpartum, but from a recovery-oriented system of care.
I can just add to that the Substance Abuse and Mental Health Services Administration through the Block Grant, and then with the additional money, CURES money that's going to the states, which is a formula grant, will support and help states expand on the priority populations they serve, which includes pregnant and parenting women. And that's been the case for a long time. More information could be gotten through Women, Children's Families at the SAMHSA website.
Hi, Grant Baldwin Injury Center. Thanks for a suite of really fantastic presentations. I have a couple of questions. My first is both for either Mishka or Linda. I wonder if you could comment, Mishka, you sort of highlighted the successes that were happening in Baltimore, sort of telescoping out. I wonder if you could comment on if there's a state writ large that you think is doing these integrated holistic services best. But, Linda, maybe you want to answer that as well. And then my second question is, you made a very compelling argument about the real opportunities that exist in the current ACA law around receiving these integrated services. As we as a country wrestle with where we are with administration change, I wonder if you could comment on sort of the realities at play and how we hold on to what's valued, such as integration.
So at risk of being criticized for this, I recently moved to Massachusetts, and I have to say with the advent of Romneycare, which predated the ACA, I think Massachusetts has a leg up on looking at how to integrate services across the spectrum, as well as what they're doing in terms of integration of substance use disorders and mental health treatment and access to MAT. They are by no means the only state that's successfully working on this. It would be unfair of me to say they're the only state that's doing this well, but they're the one I'm the most familiar with at the moment. I think every American needs to think about what we're about to embark on. And I don't want to take a political stance on this, but I can tell you that I'm concerned about anything that would change parity or access that my family members have to health care that they did not have before ACA. That's a personal statement, but I think it's an important personal statement. This is not health care access for others out there. This is us. And so I don't know what the answers are. I think many states have approached this very differently. Some states have expanded Medicaid, some haven't. We've learned a lot, and we need to think carefully about how we proceed.
The only thing I would add to that is that one of the consequences of the opioid epidemic has been a huge amount of attention to substance use disorders in society, and that attention's not going to go away with changes in federal policy per se. In fact, during the election campaign, every single candidate, Republican or Democrat, all had at least one statement in which they acknowledged addiction as a disease. And having worked with people on all sides of the legislature, I can say that I feel that I just moved to Virginia, and I feel that there, like, everybody gets parts of this. And I think it's focusing on the comprehensive model on care, on the life course piece of it, and really thinking about what the role states have in terms of legislating health care related policy. And there's lots of examples of good policy out there too.
Okay, I think we have a question from online.
We have several. Is there any thought of how compensation based on patient perception of care via Press-Ganey surveys has contributed to the prescribing practices of opioids?
So this question is related to the history of pain as the fifth vital sign, the JCAHO regulations that were historically happened in concert with the increase in prescribing. There are data looking at the institution of prescribing guidelines in emergency department contexts and no effect on Press-Ganey scores. So there's no evidence that having intelligent use of opioid prescribing in medical care settings negatively impacts Press-Ganey scores, and by extension, patient satisfaction.
What?
Randy Elder from OADS. I'm curious about the getting into more details of the relationship between changes in prescription practices, and heroin use. And in particular, what the evidence is on that relationship for people who are already habitual users of opioids, and whether the relationship holds or if those people do in fact need greater attention to assure that they don't self-medicate with illicit drugs.
Right, so the one slide I had up showing that 7 out of 10 of the heroin users had also previously misused prescription opioids. So we see that the intersection of the drugs is troubling. So prescription opioids, the misuse of those, heroin, the illicitly manufactured fentanyl. I think it's a complicated epidemic, and we need to understand the use of all those drugs.
Thanks.
We have another one online.
We are attempting to incorporate a family planning question in all our health risk assessments across the country. We are using the "would you like to have a baby this year" question for adult women. Is there a possible differently worded question for adolescents and a general population?
For adolescents? To my knowledge, the one key question, would you like to become pregnant in the next year, is a slight bit more general than have a baby, and perhaps preferable, and would work as well, to my knowledge, with adolescents as with any aged, reproductive age women.
Okay, another online.
Is there a difference in opioid dependency between African American women and their ethnic counterparts?
So this is a really big, complex, and very good question. So we know from overdose data that overdose death rates have increased far more for white Americans than for Black or Hispanic Americans. And that maps onto, to some extent, an increase in opioid addiction within those subpopulations as well. And that relates to a large extent to prescribing practices in which white Americans presenting to emergency department settings, et cetera, with pain were far more likely to receive opioid prescriptions than Black Americans were.
We have a question here in the room.
Yeah, my question is similar to the last question. The opiate epidemic is not new to America. It's been around for many years. In the 60s, we know that there was a heroin epidemic that hit Harlem, which was an all-Black community. I want to ask, is there an ethnic disparity among opiate users who use prescription drugs and those who use street-level drugs? And if so, is part of the government's movement to address the opiate epidemic motivated by that disparity? I guess the question I'm asking is, does it seem to be that we're doing more now to address opiate use, misuse, and morbidity because more white people are overdosing compared to when Black people were overdosing? We didn't seem to get the same kind of attention.
The short answer is yes. And to dial back your historical timeline, the first opioid epidemic in the United States was at the end of the 19th century. And it was overwhelmingly white, upper class, upper middle class women who were exposed to opioids through their physician who was prescribing opioids for the treatment of menstrual pain, hysteria, female ailments, etc. And at that time, it was a public health response. And we forget that the idea of addiction as a disease is actually not a new one. It's an old one, and it was for the big chunk of the middle part of the 20th century that we turned away from that paradigm. I'm forgetting his name right now, but he wrote a book on legislation of morality in 1970, the year before Nixon institutes the war on drugs, in which he writes that addiction has been common across society, across different strata of society, but it's the color of the face of the individual we associate with the drug problem that determines the federal response. So in the 1900s, when it was a white woman with an addiction, it was a public health response. In the 1960s, when it was Black men and women, who had addictions, it was a criminal justice response. And now, when the face of the epidemic is white, it's a public health response. So we have to acknowledge this history, I think. But I think it's very important to seize the moment, right? To seize this attention, to seize this energy that exists at all levels of government, and try and use it to put programming into place such that when the color of the face of the individual associated with the next drug epidemic is non-white, that we have a public health system of care, and we have the availability of treatment, and we've decriminalized substance use, such that we don't fall back into the old criminalization paradigm.
I'd like to thank all of our presenters. I'd like to thank also like to thank all of those who helped organize this session from the HHS Office of Women's Health. Please join us again next month for Public Health Grand Rounds. Thank you.